Good morning, Chair. I can confirm that we are now live.
Thank you, Tom, and good morning, everybody, and welcome to the board of NHS Coventry and Warwickshire ICB and NHS Herefordshire and Worcestershire ICB meeting in common today. And welcome to everybody attending the meeting and indeed members of the public who may be observing us today. I particularly wanted to welcome Sue Whelan. Sue is the chair of George Eliot and South Warwickshire Foundation Trust, and Sue is joining us for her first meeting today as chair of those two organisations and is a participant in the board today. So welcome, Sue. We do have a few apologies, so I'll just note those for the minutes. We have apologies from Addy Hardy, Sue Noyes and Adam Carson, I believe. And we're delighted that we've got Healthwatch representation, I believe, from Coventry, Warwickshire and indeed Worcestershire. So hopefully I've got that right, and that should be Stuart, Chris and Don that we were expecting today. So welcome to everybody. I think I've covered all the apologies. And I know that Paul Walker was going to be a little late joining us, but we are expecting him today from Herefordshire Council. So declarations of interest, if there are any, please do take a moment to highlight those in relation to items on the agenda. Obviously, we do have a conflicts of interest or a register of interests available for members of the public to look at, and it's in our governance log in the board papers. And Hannah, you've confirmed we're already quorate, so I think we can proceed with the meeting. So just moving on to the governance log, we have only one open action, I believe, and that's not due yet. So we'll come back to that at the next meeting. I don't know if there's any other comments, Hannah, that you wanted to make regarding the governance log at all?
Thank you. Only that we have now scheduled all our board spotlights throughout the year. So those have been scheduled. We've also included all decisions that have been made in the last 12 months, just for the board's reference. So these have been separated into 3 different tabs, one for Coventry and Warwickshire, one for Herefordshire and Worcestershire, and one for the last 2 meetings that we have held in common, which have been aligned decisions. So just to explain why there are so many tabs on the governance log, Chair.
Thank you, Hannah. And looking forward to July, which is obviously our next formal public board, the spotlight currently planned is end-of-life care, which we did say was an area when we discussed in our development sessions, an area that we felt was an opportunity to improve the care that we provided. One thing I did wonder if I could ask executive colleagues to do is looking at, and I think it's mentioned in Simon's CEO report, goal 1 of the Neighbourhood Health Framework lists a whole load of priorities in terms of areas for improving health outcomes, and we might just want, I don't know if this is something sort of Mary and Rachel might do, but might just want to just make sure that the priority areas that have been highlighted in the Neighbourhood Health Framework are ones that we've covered somewhere. I think most of them are referenced, but there may be some long-term conditions. We just might want to sort of double check that the board has the opportunity to cover all those outcomes. So I wonder, Hannah, if we could note that and maybe just ask Rachel and Mary to have a look at that, and just to make sure we've got the opportunity to look at everything that's been highlighted as a priority. I think many things have been, but it seemed like an opportunity just to refresh that list in case we've missed anything. Okay, that was all I wanted to comment on that. So if there's no comments from anyone else, we just move on to the minutes of previous meetings held, which was the 18th of March. And I just would like to confirm whether everyone is happy to approve it who was present. Yeah, no questions or queries. Lovely. So we'll consider those approved. We move on to the patient and public voice section of our agenda. On this occasion, we have no questions from the public, but if any member of the public is watching us today, we do welcome questions. I think we did receive some questions earlier in the period, but we were able to respond to those. So we will obviously try and respond as quickly as we can in any case, but please do feel free to submit any questions in future. So today's spotlight is on children and young people. It is an area we explored in quite some depth within our development session, really in preparation for this public meeting. But as ever, we have a patient story that we want to share with you all to bring the story to get to life, I think, and really kind of help us focus on this really important priority, which is a key area of focus in the neighbourhood health framework, actually. So without any further ado, I will hand over to Kath Cobain, please. Kath.
Thank you, Chair, and good morning, everybody. Before I start this story, I just want to give a short sort of a trigger warning. This story does contain references to struggles with mental health, including self-harm and suicide. We will put information on the website for any of the members of the public that would like to access this. But if people are affected, please take the time out as usual. So this patient story is about Adam and Harry, and is anonymised as well. This patient story is shared by a mother and describes the experiences of her two sons, Adam and Harry, as they navigated neurodivergent diagnosis, mental health challenges, and an education system during adolescence. Adam and Harry had positive early childhoods. Both were bright, active, and engaged well at preschool and primary school. No significant concerns were raised during those early years, and both boys transitioned into secondary education, appearing ready and enthusiastic. I'll start first with Adam's story. Adam started secondary school in 2019. 6 months later, the COVID-19 pandemic disrupted schooling and removed many of the structures he relied on. As Adam was not known to services or on the school's special education needs and disabilities, known as SEND register, no additional support was in place during this period. As schooling resumed, Adam began to struggle academically and socially. He became increasingly withdrawn, fatigued, and anxious. But as he was quiet and compliant, these difficulties were not initially identified as a cause for concern. By year 10, his mental health had deteriorated significantly, culminating in self-harm and suicidal thoughts. Adam was referred to Child and Adolescent Mental Health Services, known as CAMS, and received timely crisis support, including a safety plan. However, once he was no longer deemed to be in immediate danger, formal support ceased. He was referred for an autism assessment with the NHS waiting times quoted as being over 2 years. During the months that followed, Adam continued to struggle, his school attendance declined, and the family felt unsupported and unclear where to turn to for help. Midway through year 11, the family prioritised Adam's well-being and supported him to study at home. His mental health improved, and with family support and tutoring, he successfully completed his GCSEs. Shortly before his 17th birthday, Adam received an autism diagnosis via a right to choose provider. This provided important clarity and understanding for both Adam and his family. He is now attending college on a reduced timetable, engaging in therapy and developing new interests. While he still experiences periods of overwhelm, these are now recognised and managed, and Adam feels more confident and hopeful about his future. So I will now move on to Harry's story. Harry started secondary school in 2022. While academically capable, he struggled with attention, impulsivity, and hyperactivity. Difficulties escalated quickly in the highly structured secondary school environment, and Harry began to receive repeated sanctions for behaviours linked to undiagnosed attention deficit hyperactivity disorder. The school supported a referral for ADHD assessment, but long waiting times meant no diagnosis or formal recognition of need for many months. During this time, Harry was frequently isolated from peers, excluded from physical activities that helped him regulate, and labelled as having behavioural problems. His self-esteem and sense of belonging were significantly affected. The family sought diagnosis via right to choose, and Harry was diagnosed with combined type ADHD. While a SEND plan was introduced at school, it was inconsistently applied and poorly monitored. Behavioural sanctions continued, and the family was informed that Harry could no longer remain at the school due to his unmanageable behaviour. The situation placed significant strain on the family. Both children were at times out of school, not because education was unsuitable, but because appropriate support was not available. Eventually, the family pursued ADHD medication. Harry's response was immediate and transformative. His concentration, confidence, and engagement in learning improved, and behavioural incidents ceased. Harry remains in school, is progressing well, and is now planning for further education. Although medication has required careful monitoring, Harry reports feeling happier, calmer, and more motivated. And I wanted to touch on the impacts that this had on the family. Throughout this period, the impact on the family was significant. Parents described living in a constant state of anxiety, trying to balance supporting both children while navigating complex systems across health and education. There were times when both boys were at home, one because he struggled to go into school and one because they were not allowed into school. This started to take a toll on family life, on the parents' own mental health and their ability to work and maintain day-to-day routines. Repeated contact from school, uncertainty about where to seek support, and the need to advocate persistently for appropriate provision placed ongoing emotional and practical strain on the family. This experience highlights the wider impact that gaps in support can have, not only on the children and young people, but on the whole family unit. There were some reflections and learnings in this. This story highlights the profound impact of delayed diagnosis, long waiting times, and inconsistent implementation of reasonable adjustments for neurodivergent children. It demonstrates how rigid systems and behaviour-led responses can worsen outcomes, while early recognition, understanding, and flexibility can dramatically improve well-being and educational engagement. With appropriate support, both Adam and Harry are now moving forward positively. Their experiences reinforces the importance of timely diagnosis, joined up health and education support, and compassionate, individualised approaches during critical periods of adolescent development. So I'll close there, and thank you very much, Chair.
Thank you, Kath. Really a powerful story. Has anyone got any comments or questions that they want to raise at this point? And I recognise we've got the spotlight item coming up and we can explore this further, but there may be some specific learning that people want to comment on. David?
Yes, thanks, Krishna, and thanks, Kath. I think that is a really powerful and very, very moving story. I think it highlights to us some things which we already know, but that we struggle to put our focus on, which are indeed the impacts of delayed diagnosis for neurodivergence for children and young people. And we know the waiting times are long, but it does show us again how important it is, because of the impacts on the individuals and of course the families, but how important it is to put resource wherever we can into shortening those waits. That's just my observation on that, but it also came clearly from the story. So thanks, Kath.
Thank you, David. A really helpful reinforcement of those key learning points. I think for me, one of the things that, and Mary might want to come in or pick this up as part of the spotlight item, but it's the challenge of signposting and navigating for people. I think for those of us who've been associated with the NHS and maybe even public services for some time, you know, we've got used to the complexities, but for somebody dealing with it I think, for the first time, or trying to navigate support, I really think that is, and for children's services in particular, it seems there's so much available, and I remember somebody trying to map out all the different children's services across all public services, a particular system, a few years back, and the lines that they were drawing in terms of how things were connected was so complex. So Mary, I don't know if you can comment on that, but that seems to me one of the kind of things that we can really try and do well, because if people know where to go, that would really be helpful. And then the only other reflection really is think family, because this is so much about, not just about the young child or the child needing support, but actually the effect on the whole family, which I think was incredibly powerful as well, because you know, the sort of impact of something going wrong like this is actually much bigger than the individual who might actually be directly affected. Mary.
Thanks, yeah, and Krishni, I couldn't agree more. I mean, we have constant feedback from the very active children and young people that we engage with and their families, that the biggest frustration is knowing who to talk to, where to go, the multiple front doors that we have for services. And even when we try and put it into one place, it's so complex. Even I couldn't understand what is called the local offer. Trying to navigate it was very complex. So when we get onto the secondary form later, that's about trying to intervene early, make sure that we wrap the services around these children where they're comfortable, rather than asking them to go out to numerous appointments and clinics and navigate a system that it doesn't really help them in the end of the day. So that's the approach that we're trying to take. But you know, there's a big transition to get from where we are to then.
Thanks, Mary. Roy, please.
Yeah, thanks for the story. I think it was a comment on the right to choose process and feeding into that discussion about the kind of complexity of navigation. Although right to choose offers speedier diagnosis, in our patch we've been working on an MDT working with schools in our voluntary sector, and actually one of the things that's apparent is right to choose is almost causing more issues with navigation and parents. It's almost thrown in a different way of children being referred. So traditionally they went through schools, they had assessment through schools and SEND process. Now they're being told to go to their GP. The lack of schools sort of intervention, sometimes they're not even aware that they've been referred to the pathway, and then there's a lack of sort of post-diagnostic support because they're not in the system. So I think right to choose, you know, has its place, but I think there's a need for us to I think connect some of the children who are being diagnosed through right to choose and almost make sure that they're linked in with other pathways, because I think it's almost sort of creating a separate stream of diagnoses that actually isn't as well linked in as it should be, and I think causes some problems for the schools when those children come back, you know, from other providers. So I think it's just one that certainly we flagged through our MDT work.
Thank you, Roy, and maybe Mary could pick that up when we come back round, if that's okay, Mary. Vicky?
Thank you. I think just building on what everybody else has said, but I guess my reflection is what I haven't heard so far in our board discussions is about advocacy services that provide that sort of central family support before they get onto the formal system. And I just guess it's something that we could think about as we go forward into neighbourhood health provision. So it's just something to reflect on and think on as we go forward.
Yeah, thank you. And that's perhaps part of that sort of initial offer, isn't it, Mary, that might be, you know, need to be central to our thinking about how we help people navigate the system. And that part of the offer could be a sort of advocacy type support for reasons we've said actually before, that, you know, some people are more able to navigate despite the challenges than others, and if you know the system a little bit, as you know, I know from experience in a different situation, on a personal level, you sometimes feel you can do these things, but not everybody is really equipped to do it either. So having that support to do it is really important. So thank you, Kath, for the story and for to the patient who shared that story with us as well, because it really does highlight the challenges that I think we have in front of us. But importantly, we've recognised this is a priority for us for all the reasons we've said, and we shall come back onto the spotlight aspect when we complete the next item, which is the Chief Executive Officer's report. So thank you very much, Kath. Anything final you wanted to add before we move on? Okay, right, Simon, over to you then for item 8, which is your report.
Thank you, Krishni, and good morning, everybody. So hopefully everybody has had a chance to read the report. I will just draw out a few items if that's okay. So firstly, the first section of the report talks through where we are with ICB transition. So probably the most important bit for the board is we have had a significant number of staff who have departed the organisation since the last board meeting. So probably somewhere in the region of 150. We're managing the rest of the £22 million savings programme through a range of other means. We've got some other departures later this summer, and obviously we've had a very strict vacancy control process which has contributed significantly. So worth noting the contribution all those members of staff have made. We've tried to we held recognition events. We've tried to make those departures, which are all voluntary redundancy departures, we've tried to make those as respectful and dignified as possible. And I'm pleased with where we are, but obviously more work to do to finish this process off. In terms of the money, that £22 million, we're banking that is all within spend plans in programme spend for 26-27. So the transaction, if you like, and the shift of those costs from back office management costs into programme costs spend on services has happened actually, and I think in time we'll do a proper reflection probably at board later this year. But I think as we stand today, that process has gone well and we've done as well as we could have done. Just moving through the report, so there's been 2 big events in Coventry since the last board meeting. Coventry City got promoted to the Premier League, but far more importantly, Mary Munvori was appointed as the permanent Chief Executive of Coventry and Warwickshire Partnership NHS Trust, so congratulations to Mary. Page 2 also gives some headlines on some prevention work, and I suspect in the forward plan we'll come back to this, but some really good tangible practical examples through Work Well, Fit Note reform and the Obesity Pathway Innovation Programme, all of which will be making a big difference hopefully to our prevention agenda. So thank you to colleagues that have worked through that. Pages 3 and 4 talk through the Strategic Commissioning Development Programme. Just to flag, we'll be starting our self-assessment in July. Rachel Danter is leading this for us. We'll be starting our self-assessment as a board. We'll be understanding our gaps, and the programme is there to help us develop capacity and competence in the areas where we think we can make a bigger impact. Moving through the report, the Neighbourhood Health Framework was published, as Krishni mentioned earlier. Probably the biggest action is we are working with a range of partners on a long list of potential neighbourhood health centre development sites, and that has to be in next week, I think. So lots and lots of work behind the scenes with general practice colleagues, with local authority colleagues, and with community service providers in particular on working out what the art of the possible is around neighbourhood health centres. Just the final bit then on the report. So we have to take to board every year our EPRR, our Emergency Planning, Response and Resilience annual reports. So those are attached, a summary of those are attached for both ICBs. And as part of the report, obviously, I'm asking the board to note all of the content, but specifically to approve the publication of both of those annual reports. So Krishni, I'll stop there. Very happy to take questions on any of those things or anything else in the report.
Thank you, Simon. Any questions or comments on the report that Simon has put forward? David?
Yeah, thanks, Krishna. Thanks, Simon. I just wanted at the kind of very start and end of the report to recognise the good work that you and the team have done, Simon, in the restructure, and to emphasise the need, which I know you already know, to continue phase 3 with the same level of kind of empathy and respect that we've shown up until now. I think those are really important, but also to link that to the last item in the report about the staff survey. Good to see the results, as good as they are. There's a huge job ahead of us, of course, to rebuild morale and to rebuild the team once we get through this process. But two things: congratulations on how it's gone so far and bringing out the need to continue in that same vein, and also the need to rebuild at the end of the process.
Thanks, David. I think absolutely right to highlight. Simon, anything you wanted to add?
No, I've 2 points very well made, and both of those things. I mean, wave 3, the consultation with the remainder of the ICB staff will start on the 1st of June, so a week on Monday, I think it is, isn't it? So we have all the plans in place for that. I mean, the good thing is, in terms of departures, we only have a need for a further small number, and it's kind of about 10 members of staff, which we probably could do through vacancy control, David. So the focus in wave 3 is very much on the right people in the right jobs and making sure the structures we have reflect the role that we now have, which of course is slightly different than the role we had 12, 18, 24 months ago. But yeah, you're right, David, to keep reminding us how important it is to do this properly and to carry on showing the levels of respect and empathy. I think the words you used, which are good words and good reminders.
Thank you. Roy, please.
Thanks, Simon. It was just a reflection on the neighbourhood framework, and obviously the from a general practice point of view, there's a big focus on access, and I think that concerns me a little bit. I think access is certainly important, but I worry that the focus on access and the sort of the national focus and political focus on GP access is actually almost distracting us from some of the more important work that general practice should be doing around continuity of care and care planning and moving into neighbourhoods, and it's disappointing to me that actually there's such a focus on GP access. I know access in our area is sort of better than average, but it feels actually the more you focus on access, potentially the less you focus on the things that we know are evidence-based around continuity of care and reducing inequalities. And I just wonder if there's sort of any reflection on how we can feed that back sort of into the national teams.
Yeah, it's a good question, Roy, and of course we all understand access to GP appointments is a big political priority, so of course it's going to be in national frameworks. I think our job locally is to reflect on the relative priorities of the elements of that framework. For us, the priority with access is to maintain current levels, and if we can make further improvements through initiatives, then do so. But for me, locally, neighbourhood health it won't be about access, because as you rightly point out, we've got some really good GP access. There's always room for improvements. We have some variation across areas, and we do need to eliminate that unwarranted variation. But the priority for us is exactly as you say, focusing on long-term condition management, multidisciplinary team, coordination of care for people that avoid the need for acute hospital activity and intervention in particular. And I think, as we'll come on to, I think in the next item, increasingly neighbourhood health, and that could be the opportunity to utilise some of these structures to deliver better care for children, I think is a local priority for us in both ICBs as well. So for me, both of those two things are a bigger priority locally than access. But we can't ignore the fact that the politicians in particular are very eager to see further improvements nationally. We just know, don't we, that we've just got to build on our strong foundations and strong performance in that sense. But we can do a lot better, I think, with some of the avoidable hospital admissions. We definitely can do a lot better with some of the joined up care for children, which you were describing in the previous item, how by talking and integrating some of these conversations better, there's a whole lot better outcome for children and families as well. So it's a good point, and Christian, I think that's a really good discussion to be having at board, that because of the national framework, we haven't necessarily got to follow it by the letter of the law. We can have our own interpretation of the bits of the framework which are most important to us.
I would support that absolutely, Simon and Roy. I think we need to we need to understand what's behind the framework and what's driving those priorities within the framework. But I think we can take a local, understanding where we are against various aspects of it, there are clearly some areas which are more of a priority for us. And certainly the one that, you know, personally I can't help moving on, you know, focusing on priority one in many ways, just because improving outcomes really feels like the most important thing we really need to do. And you know, there are other elements of that perhaps I think we can still do better at, transforming care through better coordination. Better coordination feels like an important area for us, but it is, yeah, it's right to say that whilst I think we recognise in some parts of the country clearly there's a far greater focus on improving access, GP access. It's rarely something that we're challenged about, is it, Simon, in truth? And therefore that probably reflects the generally good standard we have, albeit there's always variation to address. So it's certainly not as high a priority perhaps for our two systems. So thank you, and absolutely want to keep this local. I'd like to bring Pete in, and I don't know, Pete, if you're going to mention, I couldn't help noticing on social media that Coventry City Council's children's services have been rated outstanding. Were you going to mention that?
Well, I wasn't questioning, because we obviously we don't like to boast, and I can't take any glory for that, because it's my colleagues in children's services. But well done to them, and I think we should absolutely recognise it here. What I was going to ask, Simon, is the other elements of the 26-27 primary care action plan around pharmacy, dentistry, optometry, just whether those requirements of putting additional demands into the ICB, and if so, in the context of a reducing workforce, just to kind of what that might mean for us as a board in what the ICB will need to prioritise due to additional demands from a smaller workforce, and just kind of board awareness of that, if you need to orientate some of your remaining staff towards new priorities which are NHS driven.
Yeah, well, good question. I mean, firstly, to pick up on the children's services, I was aware of the CQC outstanding rating, but it was embargoed until Monday, and because we published the papers last week, we weren't able to include that. But we'll make sure we make reference to that in the July papers. Yeah, Pete, really good question on pharmacy, optometry, and dentistry. It's not something that concerns me greatly, because we have some really kind of high performing people in the team who really excel in this area. I think there is a risk that were we to lose any of those select individuals, it would be a problem, and we'd have to, it's one of those areas that's quite specialised, quite niche, and it takes a bit of learning. But we're lucky, as things stand today, in both ICBs, we've got a really good wider primary care team. They're good at general practice commissioning, but actually we've got a lot of local capacity and expertise around dental, pharmacy and optometry commissioning as well. We clearly haven't spent as much time in the last 5 or 6 years on that, but actually certainly in Herefordshire and Worcestershire, dental access was appalling, and it had to be something that we worked quite hard on anyway. So we are probably 3.5 years into a journey of having to have done a lot of work on understanding needs and having a clear commissioning plan for some of those areas. And we've been able to use some of that learning to roll into Coventry and Warwickshire as well, where, you know, access is better, but still room for improvement. So, you know, as things stand today, we've got some really strong local capacity and expertise. I guess we'll just have to flag and have a conversation if we were to lose any of those key individuals. That would be the right way to answer.
Thank you, Pete, and we will note our congratulations, Pete, to Coventry City Council, and we'll repeat that in July as well. But it's a really positive achievement for Coventry, alongside Coventry Football Club achieving its position in the Championship as well. and of course Mary's appointment. So that's 3 positive things for Coventry, which we should note today. I did want to just come back to some of the content in Simon's report around prevention. I think it's really good that we focused on that, and really good to see that. And I did wonder, and I might want to bring perhaps Becky to comment on this as well, Becky and Pete, but the Work Well example, in fact, interestingly, I think the conversation, Becky, we had at the Health and Wellbeing Board for Warwickshire last week, there was a bit of a focus on the importance of work, or there was reference to the importance of work and in terms of health and the local economy. And I just wonder whether there's an opportunity to, you know, we don't want to double handle these things, but to tell a bit more of a story about Work Well and some of the work we're doing and at any of our health and wellbeing boards, really. And there may be it may be useful for, you know, Worcestershire and Herefordshire as well, but because it struck me as one of the things that our local councillor representatives might be quite interested in. So I don't know what your thoughts are, whether Pete, Becky, you know, Simon, you were obviously there last week as well, whether you feel that might be useful. Becky?
Yeah, I do think it would be useful, Chair, and David might want to, there you go, might want to come in as well. So we've been having some discussions jointly about how we now move forward Work Well over the next 3 years and get more impact for what we're doing in that space. And I think, as you said, we had a discussion, didn't we, about inequalities and the real opportunity that Work Well gives us to enable us to tackle health inequalities. So I think it is definitely something we should have a focus on here and in the Health and Wellbeing Board. And I think some of the additional things that have come through and the Fitnote opportunity as well will help us to really bring it forward.
Great, thanks, Becky. David?
Yeah, I was just going to say, Krishni, that we had a deep dive into work and health at the Herefordshire Health and Wellbeing Board on Monday this week. And a couple of months ago, there was a deep dive into, or maybe slightly longer than a couple of months ago, into the Worcestershire Health and Wellbeing Board as well. I think it's back on the agenda again for September in Worcestershire. And I think the important thing is, when we look at those public health models around what drives health outcomes, there's this 80-20 split, that 80% of your health outcomes are influenced by wider social determinants. When you look at the breakdown of that 80%, one of the biggest contributors is kind of employment, income, the ability to support your family, etc. So really important for a Health and Wellbeing Board agenda. So I fully endorse that.
Thank you. So yeah, so definitely one I think we should work together on to make sure that the work we're doing is illustrated, really, because it's a real opportunity on the health and work agenda. So thank you for that. So I think, Simon, you were only looking for formal approval on the one item within your paper, which was the approval for publication of both ICB's annual EPRR reports. That's emergency for members of the public, emergency preparedness, resilience, and something else beginning with R, which has now momentarily escaped.
I think, isn't it?
Response. Okay. So we have 2 reports for both ICBs, and we do need to approve publication. So everyone content to support that. Thank you very much. And we note the rest of the report. So thank you very much, Simon. OK, so we go now on to the spotlight item, which is following the theme of children and young people, as we said when I introduced the patient story earlier. And it's over to Mary for this. Thank you, Mary.
Okay, thank you, Chair. So, colleagues, I mean, this report really outlines the cluster ICB commitment to working in partnership with all statutory organisations across the cluster, with children and young people as part of the population and their families and carers in our strategic commissioning and integration function to really help to improve the outcomes for those children and families. There's a lot being discussed nationally in the last 5 to 6 years about children's development and some of the concerns nationally about that. And it's obviously influenced by some of the things we've discussed already this morning. some of the inequalities, deprivation, neurodiversity, education outcomes. It's all part of really recognising that the first few years of a child's life is vitally important for their development and for society, to help us in society to grow and deliver as well. So it's really giving us a position statement, both nationally and locally in our cluster, about children and young people. Some of the demographics locally as well it'll give us, and then this report gives us some ICB current priorities, just so everyone's crystal clear of the current priorities. And then at the end I'll talk about the next steps of cluster-wide development related to children. So nationally, you can see from the report there is now a plethora of national policy related to children. Probably I've never seen so much before. A lot of it has a lot of overlap between it, but I think that's good and strong in some areas. So giving every child the best start in life in 2025 really did focus on that early years development and the inclusion and family support needed, and particularly language, developing language in children. I've met with a lot of schools in the last couple of years, and one of the concerns from schools is the language development in a reception class. So trying to help and support families and communities through a range of methods, be it voluntary, be it statutory services, be it community services, to help to develop those children as part of the population. It's got 5 strategic priorities: the every child best start in life policy, which you can see outlined there. I'm just going to pick out a couple I think are really pertinent to ICBs, although they all are relevant. The integrated health and early years services, so really strengthening that coordination across maternity, health visiting, SEND and family hubs to deliver seamless support. Goes back to the discussion earlier, there are many routes into services, much confusion. It's about having an integrated approach. And a skilled and sustainable workforce. With the increasing demand for children's services, which we'll come on to later, the workforce planning nationally is not catching up with that, and we need to develop more workforce with the right skills in proactive early intervention with children and families to prevent that escalation into needing lots of different professionals supporting them in their needs. And then we have the neighbourhood health for children, which Roy mentioned earlier. So that's really focusing on that multidisciplinary team approach based around schools and communities, early intervention, focusing on some of the health issues like long-term conditions, proactive management of those. We have some examples in our cluster where this is absolute best practice, there's no doubt about it. And through the PINS project, it was a national project which was around schools and integrated teams. The outcomes for those children and the feedback from their families and the schools particularly has been excellent, and it's part of the model that we want to roll out across the whole cluster to get that early intervention embedded in practice. And then for the slightly older children, there's the Youth Matters strategy, which is the vision developed by some teenagers and young adults about what they feel they need to support their ongoing development, to give them the skills and opportunities for going into adulthood. And it's really, and when you read it, you do stop and think, well, this is what you'd expect as a child. You'd expect, youth centres, you'd expect to be able to go out and socialise as a child and make friends and have after school activities. And this is really important to children and young people now, particularly those teenage years. And there's a strategy to help us to improve that, to give them better wellbeing and more opportunities. Then there's obviously safeguarding children. There's revised statutory guidance, and we're a statutory part of that system, about how we should support in an integrated way across statutory organisations those children at risk, and again the prevention aspects of that are really important. Probably the biggest national context at the moment and national policy change is the SEND and neurodivergence new reforms that were sent to us earlier this year. Now the consultation for this has just completed, so it's gone back into central government, so we'll await the outcomes of it. But this is a decade-long shift towards that more inclusive mainstream school-focused system for children and young people with SEND. And our story at the beginning of the session showed exactly the need for that. So existing duties and rights of people with SEND remain the same until there's new legislation in place. So just assurance to the public, nothing is changing until the new legislation begins. But you know, there is a national picture where it's now estimated nationally that 15 to 20% of children in the UK are considered neurodivergent. That is in the last 10 years, that is a massive shift from about 1 to 2% that was believed to be neurodivergent then. And waiting list, for example of that, on the impact on services, waiting lists for autism assessments have risen by over 300% nationally since 2021. And that's something in waiting list management we've never seen, particularly in the NHS, ever that level of increase nationally. So as part of the consultation and to support that early intervention in schools largely, the government has now announced a series of initiatives significantly changing the current approach. So an inclusive mainstream fund to add to existing core SEND funding. Schools will get additional funding to support small group and targeted interventions for children with additional needs. An expert at hand service, it's quite an interesting term, but it's called expert at hand service. So the schools will be able to draw on that multi-agency support that they'll need largely from speech and language therapists, educational psychologists and occupational therapists. Although I'm aware some areas are talking about the need for other expert at hands like emotional health and wellbeing expert at hands as well. So this support will be available to all children, not just those the current EHCP. And then there's national inclusion standards, a digital library of resources. Excuse me, colleagues, I've got the bug. And then there'll be need for an inclusion strategy as well, nationally as well. So EHCPs, the current education, health and care plans, will be reserved for the most complex cases. But individual support plans will be for all children, additional needs. That is the big change for the SEND population at the moment. So that vision by 2030 of EHCPs will be reserved for the really complex cases is quite a significant change. And all these national strategies together show the need for reinforcement of working together across health, education, schools, and the statutory and voluntary services that we have to support the change, the transformation that we need. So moving on to our cluster demographics, you can see we've got over 366,000 children across our cluster, with Coventry showing the highest ethnic diverse child population as part of their population. And while most are classed as healthy, there are specific areas in our cluster which have some health and developmental challenges, often linked to areas of deprivation. I just provided some examples there. We provided some examples of childhood obesity, where it's more prevalent. Children living in poverty across our cluster, the percentages that are classed as living in poverty. The high SEND prevalence, it's a particular issue for Hereford and Worcestershire. There's been lots of analysis as to why. The general belief there's more awareness from the population of the ability to access services, so the diagnoses are more prevalent, but that is still being looked at. And then young adults not in education, training or employment. So you can see we have 5% of those children in Hereford Worcester without not in employment. And interestingly and really positively in Coventry, the proportion of 16 to 17-year-olds on SEND support who are not in education and training is below the regional and national averages. So they've done a really positive piece of work with those children and young people in Coventry. So all of that together shows, the need for early intervention support, and then education is a big part of attainment for children and development. And I'm not an education expert; others on the gallery are. So we've just provided you some of the outcomes that we're currently achieving in good level of development in the first year of school across our cluster, and then throughout the education system. And we do reflect the national picture largely. There are some areas of slight improvement, there's some areas slightly under, but we do reflect the national picture. But there is an ambition nationally, particularly on that good level of development in the reception class, for all across the country to achieve 75% by 2028, which isn't that far away. So there's a lot of work to do to improve those outcomes. Moving us on to our statutory requirements and the current priorities for the cluster. So statutory requirements, I won't go through all of them, you can see them listed there. And just for assurance to the board, we are maintaining all our statutory requirements in the ICB cluster transition at the moment. We are working hard to make sure the changes don't affect that. But there are some key areas of focus that we are focusing on currently. So emotional health and well-being of children and young people, and that's become a national priority as well, with again a big increase in demand for mental health support. And talking to a lot of GPs across the system, they're seeing that in primary care particularly as well. And nationally, it's now estimated 20% of children and young people have a probable mental disorder. So the 10-year plan gave us a key requirement to ensure full coverage of mental health teams in schools by 29-30. And an improving ease of access to the necessary level of support with a no wrong front door approach. And we have plans in place to achieve full coverage for that. If we get a group of families together and talking to some of our parent carer forums, their biggest area of concern is the multiple moves for mental health support that they have between services. So that no wrong front door approach, where the referral is taken and we support where the patient or the family is seen, is a key aspect for us, and I think will improve access to services. And you can see some of the work we're doing around that at the moment in mental health. So the SEND reform, in June this year, the 4 local authority areas, we've got to deliver a SEND reform plan, which as ICBs we must required to co-produce and co-design. And if approved, that we will get quite a significant amount of national resource to support the elements of the plan I described earlier. It also helps the local authorities to resource a large proportion of their high needs funding deficits where that is in place in our cluster as well. And that supports the schools and colleges for individual children. Whilst we are going through this transformation for SEND reform, and that's due for full implementation in 2029 post legislation, we have a significant challenge now, as we've mentioned already. We have right to choose, we have NHS services providing assessments, particularly for neurodiversity, and we have demand outstripping capacity in every area at the moment. And we have national inspection processes across Ofsted and the CQC that highlight the significance of the waiting times in our cluster. So from a commissioning perspective, while we wait for those reforms to embed, we've agreed a 3-year investment standard for children and young people, aiming to address those waits and support those children pre and post diagnosis, as I think Roy described earlier. We're in the 2nd year of that investment, and we're about to agree the 3rd year. And the focus is on those children waiting a very long time, largely for an autism or ADHD diagnosis, to make sure they access the service and the treatment, if necessary, as quickly as possible. Because 2 years when we're waiting is a long time in a child's life. So we are putting significant investment into that to support that whilst the reform goes on. Neighbourhood health, I won't go into it, describe neighbourhood health, and Roy's discussed a bit of it, but Vicky, I do take your point of advocacy, and I think we will make sure in the neighbourhood health for children, young people, that could be a part of the site, particularly the signposting for those families that struggle to understand the services. But we are working on the blueprints across the cluster through the place-based care collaboratives to design how neighbourhood health for children will work in practice and achieve those outcomes. And then transition to adulthood is a really important and vital part of the development of children. I've learned a lot about this in the last couple of years, and it should be a really purposeful planned process of moving between services, and should start typically at the age of 14. Interesting, when I met with the group of the teenagers and described this to them, 14-year-olds weren't really interested, but it's important that we do start a process with them, particularly for those with a long-term condition. So those age-appropriate care is in place, and they can learn independence in their own condition before they transition to adulthood is really important. So across the cluster, we have really some areas of excellent practice in this, and there's some transition networks that are in place. And we're going to try and encourage learning the best from across both ICBs, parts of the cluster, to really improve that transition into adulthood, particularly with a health lean on that, because that's really important. And then a vital focus is education and co-production with children and young people. So whilst all our services, adults and children, developing them in the commissioning process with our population's importance, I think it's even more vital for children, young people and families and carers to make sure that we're meeting the need that's appropriate for those children, particularly with a neurodivergence population. We're very fortunate in this cluster, benchmarking with others at the moment. We have available very strong and effective children and young people engagement and co-production groups and links in the 4 areas of the cluster. And I've given 2 examples there, but all the 4 areas are strong. We have Impact in Warwickshire, very, very strong children's voice about their outcomes that they would like to see for themselves and their families. And the same in Worcestershire, Voices United, who've designed their own outcomes. You can see them listed there. And they really enjoy doing that as a process as well. And they keep bringing us back to when we're in meetings with them, they keep bringing us back to these outcomes, which is powerful from those children. And we need to continue to use their voices in a meaningful way to support the commissioning decisions we're going to make going forward, and evaluations of our services in the commissioning cycle as well. And you can see the 3 main themes. And first, and the loudest of all of them, is why do we have to tell our story in health many, many times? We have to tell the same story to the same people over and over again. And one of the children, very articulate, said, is there not a way of putting in a single assessment process, which I thought was, I didn't say we've tried that much a few times, but that was their rationale. They can't understand why we do it. The need to develop staff to understand and manage neurodiversity. There's a belief from children and young people with neurodiversity that our workforce don't understand their needs, and the need to put in better reasonable adjustments in services to manage need as well is the 3 main themes coming out from the children's voices. So I think whilst we fully acknowledge that the place-based local authority arrangements and effective partnerships will plan and deliver most of the range of children and young people services, and do the joint commissioning at a place-based level, and their own strategies, etc., because the needs of children in the 4 areas are different. We would like, from a cluster approach, to work together to share best practice and learning, enhance those joint commissioning arrangements in a more coordinated way than we probably previously have done. And we want to develop more enhanced intelligence related to the needs of children and young people now and in the future to enable that planning from a strategic commissioning perspective. And we want to enable the agreement of a cluster-wide strategy, a very high-level strategy, co-produced with children and young people, and which outlines the vision and ambition for the children and young people's population for the future. And to sort of start the work on that and the thinking on that. And we may change those initial discussions. We want to facilitate a workshop in the autumn with senior leaders across health, social care, public health and schools, and the children and young people to begin the co-design of a commissioning plan for the next 5 years. So we're making sure that the investment that we have available is targeted in the right areas. It will be delivering at the place-based local authority, but that we're targeting it in the right areas. And I'm sure we won't get this right first time, but it's an opportunity for the senior leaders across the cluster to come together to decide how the future looks. So happy to take any questions and then go through the recommendations if that's okay, Christian.
Thank you, Mary. I'll just open it up then for comments or questions. Nigel, please.
So thank you for that, Mary. That was a really good report on what is one of our key priorities. I've just got a question around neighbourhood delivery and children and young people. Now, when neighbourhood services were rolled out, they initially focused on cohorts which were predominantly frail and elderly, and a lot of the work that's gone in, a lot of really good work has been outside of the neighbourhood framework. Are we assured that we will develop the metrics and the assessment to make sure that the children and young people sort of outcomes under goal 1 are actually being monitored by neighbourhoods, and actually there is accountability there, because there is a risk that they could remain sidelined because that work hasn't traditionally been in that area.
Yeah, interesting, Nigel. We had this exactly the same discussion the other day. It's got to have equal priority for children and young people. It's got to be delivered at place. It's got to be agreed at place and delivered at place. We want to see the overall outcomes obviously improve, but I do. If we just focus on the cohorts that you mentioned, we will. I think we will have missed a trick with neighbourhood health because of all the early intervention, prevention, integration that is vital for children and young people. So we will be definitely, as part of the neighbourhood health framework, enhancing it to make sure it includes those children and young people.
Thanks, Nigel. Mary?
Thank you, Mary. So a couple of reflections. Clearly, with that increased demand and recognition in neurodivergent needs, I don't think we'll ever have enough capacity to meet all of that. So the focus really ought to be on less of the diagnostic pathway, so medicalizing everything, to thinking more about, how do we support the individuals on a needs and function basis. And then my next point then, thinking about, our collective mass as a cluster and as partners here, how do we start to think about our workforce development and our workforce plan? So wherever children and their families touch, they can get that support. And I know this is big because from a health perspective, the way we can think about our workforce plans probably completely different. And I'm not sure that it will tackle the sort of issues that we've got. My third point is really around the mental health support teams. I don't know, and I've just made a note for myself to check. I don't think the focus of those teams is necessarily targeted towards children who are neurodivergent. It may be the mental well-being, emotional sort of needs. And if the neurodivergent element is not taken into account, I think that's probably where we've got an opportunity to change gear on that. So it tackles both, because actually what we are seeing is probably much more of the neurodivergent need than there is the sort of core mental disorder type situations. So opportunity to work collectively as a whole workforce and think about what we can do differently. A real focus on that early identification and intervention based on needs and function rather than necessarily diagnostic processes. And then just to think about how do we perhaps refocus that support in schools and colleges from the offer from the mental health support teams.
Thank you, Mary. Is that okay to come in, Krishni? So, I mean, three
really good
points, and those are sort of things I'd really like to debate in that sort of workshop. I mean, yeah, I think we've got such a backlog of demand for assessments now. I think we've got to address those through this 3-year plan whilst we're implementing that SEND reform and early intervention. So it's a two-pronged approach really to try and address that. And then the mental health support, I think we do need to be very clear with all providers about neurodiversity they should not stop access to services, and I think different criteria are in place across our cluster. We do need to make sure there's a standardised approach to that. And then workforce development, and the children themselves said it, I think there is an opportunity as a cluster to look at workforce development. I agree, Mary, with it. We're never going to have enough. There's got to be a look at what roles we could put in place that maybe aren't qualified roles, but are unqualified roles that support these children in their development, and through our joint commissioning arrangements there may be an opportunity to do that. But those are really 3 good things we could debate in that workshop.
Thank you, Mary, for raising those, and Mary for responding. Becky?
Thank you, Chair. Probably a bit of a build on some of Mary's points. We've got a real opportunity, I think, as we develop experts at hand across the cluster to make sure that it's aligned with mental health support teams in schools. And we've already started to reach out to colleagues within CWPT about how do we make sure that what we develop aligns and complements the functions that we will have in reaching into schools, supporting all children. And obviously the whole point is that fewer children need to have more specialist support as we move forward and develop that offer. really supportive of the priorities. I think there is something about how we update the performance reports that come to this board. So actually, if we really want to address improvements around mental health access and those long waits, we need to be able to see what they are and track them. I absolutely get Mary's point that there is work that we need to do that means that actually people don't feel the need to have those diagnoses and get the support that they need before it. But I think if we're going to commit to that, we need to be able to track the performance.
Good point, Becky. Yeah, it's helpful.
Thank you, Becky. Yeah, I think if there are, where we're saying something is a real priority, we need to be making sure we are measuring our progress against it. I think, it's a really important general principle, isn't it? So it is something we should be looking at. Some really good points there, Becky, as well. Thank you, David.
Thanks, Krishni, and thanks, Mary, as well. Just building on the point that Becky made there, it's a small point, but on page 5, we've got key performance indicators, and we're actually quoting different KPIs for Hereford and Worcester from the ones for Coventry and Warwickshire. So I think that kind of consistency helps us to get a better view of it from the board point of view. But what I wanted to say really was, firstly, how powerful it is to see those children's voices and actually hearing what the children actually need and want and being able to respond to that. I think that's a really powerful part of it. Secondly, is how encouraging it is to see so many really well targeted initiatives. These are clearly the right initiatives, or seem to me to be the right initiatives, and there are a lot of them coming down, a lot of them being picked up as well. So I feel very encouraged by those initiatives and how they're presented and how we're working on them. And the third is the importance, which I'm sure we also understand anyway, the importance of working with our local authority colleagues on these items. I was at the Worcestershire Health and Wellbeing Board yesterday, and there's a big presentation about the huge impact that their Best Start in Life programme had and how long that had been running for. And that reminded me again of how powerful we are when working together across the system with our local authority colleagues. So that was a point for me to bear in mind there as well.
Thank you, David. And this is certainly an area where we absolutely need to be, if there's one thing where multidisciplinary team working, and I mean literally multidisciplinary team working across literally all our partners, I think this has got to be it, just partly because of the complexity of service offer that we have as well, and for all the reasons we've said about families and children finding it so hard to navigate the system. I think it's quite interesting. It just that children and young people tell us exactly the same thing as adults. If there's one thing we need to fix in integrated care, it's the need not to tell their story repeatedly. That's what everybody who uses our services tells us, and we really have to get that right, because I think we could make such a difference to the way people feel about the care they receive and can access if actually they don't have to tell their story multiple times. So that's an interesting one, just to see that at every age that is a factor for us to address, really. Mary, was there anything specific in what David said that you wanted to come back on? You're happy for me to just come?
Full agreement, I think.
Yeah. Okay, last few points then. Aman, please.
Yeah, thank you, Krishni. Thank you, Mary. I think a lot of the points have been covered. I was just going to ask about the workforce risk around delivery of this, because obviously capacity will be an issue. But also, I was just reflecting on my own personal experience of a son who did self-harm, and is there work we need to do around education around with teachers in terms of how they handle that situation? So just to give you an example, he actually did it in the classroom and the teacher wasn't prepared, and the impact it had on that teacher. So I think we need to think about how we educate beyond the professionals and support those individuals in dealing with those kind of situations. So there was that. What came across in this was the focus on co-creation with our with the voices of those children and young people and their families, which I think is really important. And I suppose my other question
think we've lost.
Oh, sorry. I don't know.
Sorry, Aman, you froze. You froze.
Sorry, I don't know. I don't know at what point I froze.
I think you said you were just about to say the other question is, I think, and then that's when we lost you.
Right. Yeah. So it's just with the multidisciplinary working approach. I think that's vital for to see the improved outcomes in this, and the long-term tracking will be really helpful. But I suppose when you've got so many people working together, how do you ensure you get that alignment, and where does the overall responsibility lie, and how are we going to make sure that people actually do what they need to do to so we can see those outcomes? So I suppose it's just some assurance around and that commitment from everyone that, you know, we're going to kind of come to some alignment. And I suppose that's where the workshop will really count, won't it, to reinforce those messages.
Thanks, Aman. Mary, do you want to come in on
Yeah, I mean, again, all very good points. And yeah, the workforce is going to be a significant challenge for us, which we do need to debate how we handle that one. I think there is an opportunity, and you know, I have to talk to other colleagues about this, but for the very complex children, and we have quite a number of very complex children that have got multiple agencies working with them, with some very frustrated parents, of having a single case management approach that is aligned with that one assessment, because they spend a lot of time almost battling the system, and we want to stop that. We want to focus on the outcomes for the child. So again, that's something we could debate. You know, some areas I think might have this cracked, so others won't, and the learning across the cluster would be helpful in that. But often we get escalated children that where it's so complex and it's been too fragmented. So I think we could focus on that definitely.
Thank you, Mary. We have Gail, please. Well, Gail, I think you've gone back on mute. There you are.
Really helpful report given the overview and so the scale and depth. And I think I just wanted to go back to just referencing children's services in Coventry that we talked about, to go from inadequate intervention to outstanding over a period of years is really, really good. And the challenge, one of the things in the Ofsted report, when I had a quick look at it, was saying very clearly, one of the elements of success for Coventry is that it had focused on trying to have a child-friendly city. So really embedding, it wasn't just a specialist area that had to own and take responsibility and drive the change for all the things that we've talked about, wider determinant system. So in a way, I think what I'm echoing is quite a lot of optimism that as a ICB, the report makes quite clear how we want to own this and locate this. Yes, there's some specialist work that needs to be done, but as Nigel was saying earlier, how do we shift some of the thinking? How do we really make sure as a system it doesn't become, we look at it, we have a conversation, we then task people to go and focus on the detail without us really owning the whole prevention, population health system change. So I think for me, there's just something about checking with you, Mary, that you have the confidence of us all, that as the key people that we are wanting to develop on this, us as an ICB will be able to respond and own and not see it as somebody else's area that then we do battle over. So for me, I think it is our level of confidence that we embed this into a whole system approach.
Yeah. Again, Gail, totally agree that the partnerships, you know, we need to continue to develop the partnerships. I do believe we need to develop, and people can challenge, the joint commissioning arrangements for children. I think the more we can get through joint commissioning, that will give us the incentive, the levers, the joint ownership of what we could achieve. And then the neighbourhood health, the prevention and that, I think if we could get those big things in place, that will help us drive together. But I think the more that we talk together, the more that we, you know, have, not very frequently, but we have those high level strategic discussions about the future for children, and we set those big outcomes, I think that it will help us to move forward.
And Gail, I think it's a great point about the sort of almost the, you know, a kind of the simple ambition of being a child-friendly city place. It's not simple to deliver, but I think it's ambitious and it sets a kind of frame for how you focus on kind of achieving that together. So I think a joint and shared and common vision for this is really, really important. And for me, that sounds like it's obviously worked for Coventry, and the opportunity, and this came up, Simon and I and colleagues around the ICB had a review recently with our NHS England regional colleagues. And one of the things we were saying is, that there is a lot of good practice in pockets of our 4 places, if you like, and that there are things that we can, if we could actually sort of, get everybody working in similar ways across the 4 places, albeit recognising different needs, but sharing the learning and improving. That would really, really help us. So it's not pockets of good practice, it's good practice across, and it should help us achieve much higher standards across the board, because there is so much good work and there is so much good learning opportunity. But I do like that point, because it's simple in its ambition, and therefore I think quite striking for us to centre ourselves around. Paul Walker, please.
Thanks, Christine, and thanks, Mary, for the report. I can't resist talking about child-friendly Coventry, because we've spent some time with colleagues in Coventry as we now embark on child-friendly Herefordshire, and the learning from Coventry and from Leeds and from other places. It is an extremely positive, appropriate, and the right strategy to pursue. And I suppose it's one way of recognising and asking people that question about policy decisions and investments. How will these decisions improve the lives of children and young people in your place? And just that single discipline kind of makes it worthwhile, and getting a wider ownership of that across kind of community, voluntary and business sectors is kind of what we're embarking on. So yeah, lots to learn, but clear ambition going forward. And I think it's right that we ask the question as to how we kind of embrace this across the wider cluster. But 2 reflections from me, lots of good points been made. I don't think we should lose the kind of sense of the strong foundations from whence we start. The outcome of the early ascend inspections has been really positive, and I will talk confidently about where we are in Herefordshire and the work that Mary and Liz have done here. Absolutely phenomenal progress that's been made, but without those strong foundations in place, it doesn't allow us to move forward on that complex and comprehensive agenda that we have. But I think there's some confidence to take, and the recognition of progress that's been made, and kind of the commitment and diligence of the teams across the systems that are making that work. And I think that just bodes as well in terms of the agenda, the challenges, but we kind of get on and make progress and continue to do well. So thank you for that. And then just the final one, and I couldn't resist, in terms of SEN reform, huge challenge. There is an inextricable link between the SEN reform plan being approved and the funding deficits that we're all carrying. They are not going to be wiped away and dealt with easily. And quite rightly, there's a challenge of a robust reform plan, which is aligned to the deficit funding proposals from the government. So system staying together and working well together to make sure that happens, because it's the only way that we're going to be successful as a successful collaboration. But as I say, strong foundations to make that work. Thank you.
Sorry, just omitted to turn myself on there. Thank you, Paul, and really good to hear that you've been sort of following through on the child-friendly Herefordshire. And absolutely, I think there are some really good foundations of joint working to get where we've already got to, and we've just got to keep that momentum, which is really, really important. So thank you. And then finally, I think it's Eamon. Am I right, Eamon?
Yeah. Thank you, Krishni. I just wanted to take us back to something that Mary alluded to early on, which is around language development, and the commitment to have strong and supported families. And there is now, I think, fairly compelling evidence, and certainly expert opinion, that language development is being impaired by screen usage. And a year is a long time in any child's life, isn't it? And I think that expert opinion now extends to no child should be using a screen before the age of 2. And I just wonder, to what extent are we actually making parents aware of that in our maternity services, for example, or through our public health work? I don't want to go down the road of social media banning, because I think that is a different issue. I think this is about how you nurture your children and how we support them. And again, I think there is, and Marie will be able to correct me, there is an expert opinion developing that there is something called acquired ADHD, which is caused by a combination of overuse of screen and lack of physical activity, and that condition is remedial to stopping those things and taking activity. And it seems to me, I mean, this is a fantastic piece of work, but there is something about, are we confident today that we're doing everything we should be to actually make sure parents across all of our cluster are aware of that, and that we're supporting them to make the changes?
Thanks, Eamon. Mary, do you want to come in on that?
Yeah, I'll make a start. I might bring other colleagues in. So yeah, and the good points. And I was on a national conference, conference, and they discussed quite a bit of this as well. Recognising there is, diagnosed ADHD and autism, but they do think that there may be a link for some children in this area. Through maternity, I'm not sure if Kath can come in, and through maternity services, is this something that's as part of the best start in life, the early start in life discussion with families, do we know, or any of my council colleagues?
Well, what we've got underneath the maternity and neonatal services is we do have like a public health group that includes local authority partners within that. So absolutely, those public health aspects that you're talking about, Eamon, are really key. And I think that will remain, and that remains in place. So absolutely, definitely, and that link between the maternity side into the health visiting place as well, really key.
Thank you. Thanks, Kath and Mary. It's probably something that, well, it's definitely an area that requires sort of probably more, if we're going to embed things like that, I think we probably need to do more work on kind of how we would do that, wouldn't we? I don't think that's I don't think that's a straightforward thing to do, but Becky may have a comment to make. Becky?
Yeah, I just wanted to pick up on Eamon's comment. Most people will be aware that our annual report for public health was about growing up online this year, and I think there is a real opportunity for us to kind of galvanise around those recommendations and think about, through kind of making every contact count, how do we get those really clear messages out to parents and to children and young people about some of the things that are in the report. So I think it is a really good point, and something that we shouldn't lose in our discussions. But there is something, I think, for all of us in the partnership to do in this space, particularly public health.
Yeah, thank you. And Mary, it sounds like something we really need to come back to as part of this workshop. The kind of, when we bring everything together, how do we, making every contact count in this context, and in the context of child-friendly policies, if you like. If we're really going to kind of adopt that approach, that needs a kind of concerted initiative, which is beyond health, isn't it? It's just, it's a bit like health in all policies. It's got to be child friendly, and the sort of essence of these messages need to be in all our policies. So it is something I think we need to come back to, and probably not going to resolve that today, but certainly I think picking up on Becky's and Eamon's point in that context would be really important. So thank you. Mary, maybe bring you in for a final comment, but just a couple of things that I just wanted to say. I mean, I do think, notwithstanding the comment that Eamon's made, but I think for older children, it is interesting that, and you reference it in your report, Mary, about digital, I mean, there are some services that I think you've given some examples of things I know we've adopted within certainly parts of our wider cluster. But I'm aware, for example, of things like chat health, which have been used really well in some settings where children, young people and families can just message and get support and advice from a text service. And it strikes me that I know all these things still need capacity, but we need a wide-ranging almost ways of people accessing, because some children and young people are better at using digital solutions than we are, and they actually feel more comfortable using digital solutions in some instances. So I think thinking about it in that way, that offer being sort of multifaceted so that people can access care in different ways or access support in different ways, I think is really important. So I was just going to highlight that really, and making sure whilst we have got waiting lists, which others have commented on, that we really are helping people to wait well and access resources to support them, because that feels to me something, signposting people to help that they can get whilst they're waiting for something more formal does feel really important. So those are just a couple of comments, Mary, and I suppose the final point I'd make is I think just emphasising inclusion. For me, everything about what we're saying is about inclusion, actually, is about making people feel they're getting services that are inclusive of their needs, recognise their needs, and support them in a way that is effective and feels appropriate to their needs. And although I think that on the one hand, one might consider that actually, kind of more expensive, to make everything inclusive and personalised, there's a bit of me that thinks it's not that straightforward, that actually if we make the offer more flexible, we can hopefully kind of use it appropriately as well. So anyway, that was just a general comment, Mary, but anything you want to finally finish on?
That's really thank you for everyone for your contributions. It's really helped me to mould this one session in the autumn as to what the themes are. So that's been fantastic. I could just like to finish with, I went out to one of the schools and spoke to a group of children, not very old children, I'd say 10, 11. Their reflections on their lives at the moment and the lack of activity, the lack of community, and I won't even describe the health services they describe. What they said made total sense, and we just do need to listen to them more about what would make sense to them. And some of that, interesting, Krishni, was, don't send letters, just send us a text. Why are you wasting that resource? So these are children that are very articulate and very, very bright. We just need to take more notice, I think. So thank you. That's really helpful for the autumn.
Thank you, Mary. And just a final point, actually, just because a couple of people raised it, and I think Sue has mentioned a comment in the text as well, just around the measures, Mary, and what we might want to do to track this. I'm conscious that Simon in his report also alluded to the new NOF for integrated care boards. I'd be very surprised if there aren't lots of children, young people aspects in that. But do we have a list of the measures that are likely to be utilised? They were due to be published last week, I think. Simon?
Yeah, they haven't been published yet, but they are imminent, as you say. I suspect this is going to be a bit fluid, the list of the metrics that they actually use, because they're testing out and trying out which set of metrics give you which set of outcomes, and obviously trying to strike the right balance. And that's certainly what's happened as well in provider land with NOF, hasn't it? That it's been a little bit evolutionary. So you're right, there'll definitely be some kind of children's commissioning type outcomes. Of course there will. And we will have to adapt our focus accordingly when those settle down, won't we?
Thanks, Simon. I mean, maybe what we need to do is just, once we have that and we have our sort of agreed priorities as well, we just need to refresh our track, what we're tracking here, so that we're all confident that the things that we've said are priorities, and in tracking our cluster strategy, we've got some metrics that really kind of tell the story that we want to be telling. So I'm not sure it's a straightforward, we'll have that for the next meeting, because we don't yet know quite what that's going to look like, but I do think we need to sort of be working towards that. So perhaps by the time we come back to the September meeting, which I know is sort of part way through the year, we will have a fuller view of the metrics we ought to be tracking here. But if anyone's got any more thoughts about that, then please do comment on that. But I think it'll be important for us to get that right, so that it does reflect the priorities that we've articulated around the outcomes we particularly want to improve. Is that okay, Mary? Shall we leave it there? Great. Thanks, everybody. So we're actually running a little bit ahead of time, but we had a good kind of discussion about that, I think, which was really helpful to be able to give it that time. If we can break for, say, 10 minutes and return at 11:10, we can continue with the delivery and quality report. So thank you very much. We'll see you shortly. And please remember to turn your camera and mic off. Thank you. Okay, well, I make it 10 past, so I think we're going to make a start. So welcome back, everybody. And we moving on to our performance and risks section, which item 10 is the delivery and quality report. So Mary and Kath, it's over to you.
Hey, thank you. I'll make a start and then bring Kath in. So this report just gives us an overview of the detailed work that happens in the Integrated Quality Performance and Assurance Committee, which had its first meeting in April and now continues as a joint governance arrangement across the cluster. So just picking up the highlights, and we are continuing to develop this report from a cluster-wide perspective, so it will change over the coming months. So urgent emergency care. So really pleasing to note the stabilisation we've seen across the whole cluster of urgent care. I particularly want to reflect on Worcestershire. The sustainability has been, best I've seen in years, to be honest, which is really positive. And across the three big indicators, the ambulance waits outside the ED departments, the 4-hour EAS standard and the 12 hours in the ED, all reflectors of good patient flow. We have seen improvements, which is positive. And a particular mention to George Eliot Hospital, who for a 4-hour standard improved their performance by over 24%, the largest increase nationally, and they are able to access capital resource as a result of that. But for patients and public, that's really great. So the next sort of planning for this is to continue the work on the neighbourhood health programmes and neighbourhood health delivery frameworks in each area to prevent avoidable attendances and keep people well, and then continue the good flow work that's happening in each of the hospitals that we just need to sustain and prepare for next winter. We've had the letter to say prepare for winter, so we're back in that cycle again. So yeah, that's really good to see. Elective and cancer, so some mixed performance here. So we are continuing to reduce our over 65 weeks for treatment. We're now in very small numbers across the cluster. Some of that well explained, so that should resolve itself. And we are overall, the elective waiting list continues to fall. So that is a good news story for our cluster. We just need to now focus on the 52-week patients waiting over a year and reduce in those areas. Cancer, again, we've got some mixed performance across the cluster. Particular issue in Worcestershire on the cancer performance, which I know through the tiering calls with the region and support from ICB staff, we are working hard to resolve that across the three indicators in cancer. And indeed, George Eliot, UHCW and Worcester Acute all remain in tiering for cancer, so it's a key focus. And there's some key specialties that are causing the sustainability problems with being able to maintain that performance. And we are only discussing as a cluster, is there any opportunity to do anything different that would help us to sustain those services, which are obviously vital for treatment and assessment. And then the only thing I want to pick up is the mental health and learning disabilities. So the individual placement and support services in Coventry and Warwickshire during the last year to February was below plan, so 280 people below plan. And it's a combination of lower than anticipated activity being provided and a quite ambitious planning assumption. So the ICB are working closely with the provider to support service improvement and address any potential underreporting of activity to support the getting us back on plan. And we have a similar issue in Hereford and Worcester. And a lot of that is to do with reporting of activity as well. So that's a key focus for us to get back into our planning cycle for those individual placement and support services. That's all I wanted to pick out from a performance point of view. Then Kath's going to come in on the quality issues.
Thank you, Mary, and pretty much everything as written. But so you'll note a number of quality issues that are in the main managed at local area, with issues that George Eliot managed with a quality improvement group that remains in place and has regional as well as local input. And so I just wanted to kind of go into a little bit more detail around. So you'll note in Coventry and Warwickshire some mental health incidents that are deeply sad and and emotive for both individuals and the wider community. And I just wanted to add some context to the report for board members. While these incidents are understandably serious and emotive, they relate to two separate ligature incidents occurring at different points in time and at different clinical settings. In both cases, formal review processes are underway and there is evidence of appropriate staff response with learning being taken forward. This also sits within a broader programme of sustained investment over recent years to reduce environmental risk, recognising that as seen nationally, risk continues to evolve in mental health services. And I just wanted to also kind of focus in on the relation to the homicide cases. I would emphasise that these are being managed in line with a national reporting framework, which requires notification where individuals have had recent contact with mental health services. So this in no way implies causation. Both cases are subject to active police investigation, and the current position is that individuals were not assessed as acutely mentally unwell at the time that they were within the criminal justice system. And we're absolutely very mindful of wider public concern in this area, and are working closely with partners to ensure oversight and things like that there. And I don't know if like Mary, as our ordinary member for mental health, wants to come in and talk about any further, any context there, but I just wanted to highlight those aspects really of the report. Thank you.
Thanks, Kath. No, you've covered it beautifully. I think it was worth adding that context given the sort of public nervousness following the tragic events in Nottingham. And of course, members will be aware that the Nottingham inquiry is ongoing. So I think it was just worth setting that context and being clear which is mental illness and which bit is related to criminality. Thank you.
Thank you, Kath, and thank you, Mary. Nigel, please.
Just a question, really. With the discussion we had earlier about the primary care delivery plan, none of those metrics from that will presumably be being reported nationally. Should we be capturing some of that primary care performance data in our delivery report?
Good question, Nigel. Mary?
I'm aware for the subcommittee of this board that we're capturing a much wider range of performance metrics. What we usually bring to this board are the key issues, but I'm more than happy to have a discussion about an overview of the system and give the very high level metrics. That wouldn't be a problem.
Thank you. And it probably feeds in, Mary, doesn't it, to that sort of actually what are the things once we know the indicators that are going to be in our NOF for the ICB, bearing in mind this is a new set of indicators that are going to be used for ICBs under the new role of a strategic commissioning role. I think we will have to review really all our reporting in that context, won't we, just to determine, and that primary care obviously will be part of that. I would expect anyway. I'd be surprised if it isn't, but it does feel like something. It's a little bit later in the piece than I would like, because we're going to be part way. I don't think they're going to be published until August, if I remember correctly, but there's a bit of work to be done. But I think it's a really good point, Nigel, that we are mindful of that, the wider role that we have as the commissioner in relation to primary care and other primary care, not just GP but primary care services. So we will reflect on that. Thank you. David, please.
Yes, thanks very much, and thanks for the report. It's really great to see the improvements, especially in UEC. It's in performance. It's really, really encouraging. So, congratulations to all involved there. The question is a question which I really kind of have to ask after press reporting. So, for elective and cancer, our waiting lists have reduced significantly, which is really great news. But do we have a feel for how much of that is due to treatments and completed pathways compared with cleansing of waiting lists?
I'm I mean, I'll make a start when some of the lead providers, Stephen might want to come in and others. So there's always a dual approach to this. Is validation of waiting lists is always an ongoing process and does help. But best practice pathways, the GIRFT work that the providers have done does influence this, and extra capacity, you know, insourcing, outsourcing has helped as well. And getting down to the next level of targets, which we're, you know, we know there's even more stretch targets, I think is going to be a challenge, and we need to all work together from a commissioning and provider point of view to understand how we achieve that.
Thank you, Mary. Stephen, I don't know whether you want to kind of comment on that aspect and
yeah, and then I add a couple of other comments. So I think there was a degree of it, but the vast majority, particularly for elective and cancer, I know for Wye Valley, Worcester and others in the group, was predominantly more activity. And so that was a change in the actual treatments and numbers. We tracked that quite closely. There is a bit of waiting list validation. The other big thing that made a difference across the country in the learning that we were getting from other trusts is around how fast we were outcoming. So there was a big thing of literally the clinics were happening that day, everything was outcome. So you were getting a real live picture in the month, not usually you wait a bit longer. So that was in there. So there was some process bit in there. I think in UEC that happened as well. There's a kind of muscle memory coming back around really good validation of your 4 hours, and I'm slightly nervous of some of the press stories and the narrative, which is almost like that's a bit user frame of that's gaming it. It's not. It's just making sure that we are absolutely on top of the people that are on our waiting list, and that we're not getting distracted by something else or over engineering anything. So I think that's an important one. But yeah, there was a lot of activity went on, David, to drive that. I think my other bit was the George Eliot one is outstanding. If I'm honest, I've done this a long time. I've not seen improvement like that. So we're doing a lot on understanding as a group. But I think my point, Mary, was those new ICS cluster meetings that are starting to appear around elective and UEC. I think there's two things. One is that good practice sharing is a better opportunity, because there's really good practice in UHCW, Swift, George Eliot. We've got some Wye Valley. I think we have to really capitalise on that. The other one for cancer, so we've done quite a lot of deep dive on cancer, because it's one I really want to push on that this year. There's obviously capacity issues. There's a lot we're changing around standardise, making sure we are using standardised and best practice processes. But again, I think the opportunity for the ICS is where there are real constraints like oncology and other things, is we come up with a strategy ourselves, not waiting for somebody else to do it, and not, it's probably bigger than an individual organisation. So it'd be really good to see how that develops, and then I think that could be a bit of a game changer for us in our things like cancer performance.
Thanks, Stephen. Mary, do you want to comment on that?
That's really helpful, Stephen. So a bit like we said for children and young people, we want to have an event across the cluster early in the autumn around elective cancer diagnostics, tertiary, SpecCom. Not to oversee what the places are doing on this, but to see what opportunities are there for sustainability in 5 years' time for oncology, for neurology, things like that, to make sure that we've got that sustainable programme in place. So really welcome your support on that, Stephen and others.
Thank you. And I think, Stephen, you've reinforced, you know, the kind of that opportunity about learning, which, you know, we've now got more trust to sort of benchmark against, close to home, if you like, with relationships well established. And I think the opportunity to really kind of make sure we're grasping the learning is fantastic. And certainly in terms of variation, I mean, it was great to see, I think, the best, I think, was it the best 4-hour performance in Herefordshire and Worcestershire since 2001. I did celebrate that, because I felt like, well, I've been here since 2022, I think, so I felt like, oh, that's something to celebrate. It is really important to really to see that. And clearly there's been a lot of improvement. I think the one thing that was striking, and it was just about this learning point really, was the variation in ambulance handovers, where I think it's over 60, where it's over 60 minutes, where Coventry and Warwickshire had achieved a much better performance than Herefordshire and Worcestershire. And again, it was really just to highlight whether there are any opportunities for learning in that, which I'll leave you to look at. But Sue, bring you in, Sue Whelan.
Thanks, Chair, and thanks to colleagues for acknowledging the George Eliot performance in terms of A&E. I just wanted to acknowledge the courage of the staff to make such fundamental changes, and that there's an absolute buzz in that department and throughout the hospital with the flow at the moment. So if anybody would like to visit, I'd be delighted to host and get them to share some of the learning firsthand. And then on to cancer very quickly. I just wanted to make the board aware that I'm very aware of the need to improve cancer services across Coventry and Warwickshire, and I've been working on expanding the joint working in cancer between Swift and UHCW, and we are investing in more oncology workforce and appointing some of those directly at Swift. This seeks to address delays in treatment of cancer and whilst galvanising the services for Coventry and North Warwickshire at the same time. So it's such a crucial and fragile part of our service that I just wanted to make everyone aware.
Thank you, Sue, and please pass on our thanks to Adam and team, with Adam being absent today. I think it's really important to recognise that improvement, and Will mentions that he was there yesterday to see the ED and the flow, and was very impressed. So that's all really positive. But I think really good to see significant improvement. Sustaining it is obviously really important, but improvement, continuous improvement, ongoing improvement is the name of the game, isn't it? We've just got to keep working on trying to maintain that kind of improving performance, and ultimately we'll all see the better results for that. And it's fantastic when we get staff engaged in that, and actually it's exciting and people feel proud of improvements they've achieved. So it can be a sort of virtuous circle, I think, continuous improvement, because it really sustains people's energy as well. So great work where that's been achieved. It's fantastic, and we should certainly recognise that. I think Vivek, please, wanted to come in.
Thanks, Krishna. It's just a small point of detail actually in the report. So under the UEC section, it talks about an 85% standard around the 45-minute maximum ambulance handover. Now, to my knowledge, no such standard exists. It's news to me if there's an 85% standard. I've checked it with my organisation. It's news to us. So I think that just perhaps needs to be looked at in the context of the narrative there. I don't dispute the narrative at all, but I don't think we should be measuring ourselves against an 85% standard if it doesn't exist. And that's why it was a maximum handover. It wasn't a maximum handover weight for 85% of people, and whoever else could wait whatever they wait. It was never designed as such. So I think that just needs to be looked at for the next time, if that's okay. Thanks, Christian.
Thanks, Vivek. Yeah. And Vivek, just to say, we can't see you, but we can see some ambulances in the background.
Yeah,
there, so I don't know quite why that is.
I just see an empty hangar with ambulances. I'm not sure what's going on there. Sorry.
No, that's all right. But we heard you clearly, and it's good to know that you're there. So is that something you can address, Mary, in the report?
Yeah,
it's in paragraph in the first. Yeah,
we'll address that.
Yeah. So we'll note that that's not perhaps a correct national standard, to quote. So we'll just need to review that, make sure we address that for the next report. Thank you, Vivek, and thank you everybody for the efforts, and bearing in mind Mary's comment about winter planning. I think it's really important that we reflect on the learning, don't we, and just sort of build on it, because clearly that we need to get it right and again show improvement from this year to winter plans for the coming winter, which does feel far away at the moment, but will come upon us in no time at all, I'm sure. So thank you. And just want to note the quality issues, obviously, that also Kath and Mary Mumburi highlighted. And Vicky, can I just check you're happy that the Quality Committee will pick up the appropriate aspects of this through your next committee?
Yeah, we'd had a discussion in the first meeting of ICPAC a few weeks ago and highlighted those issues and particularly discussed the learning, and that's and Kath has shared that. So we will monitor that on an ongoing basis.
Great, thank you very much, Vicky. So we'll note all of that, thank you. And move on then to the item 11, which is financial plan and delivery. So Mark, over to you. We can't hear you, Mark, even though your microphone is not on mute by the look of it. Pause for slight technical problem. Just wait to see if we can connect Mark. If not, we can perhaps come back to that.
He's looks like he's heading into my office.
Okay, just bear with us, folks. The quickest fix is to move office, isn't it, rather than try and sort out the technical issue there. Can we hear you now, Mark?
Sorry, Chair. Yes, unfortunately, my machine's just crashed at the same time, so I've just run across offices.
Okay, over to you. Thanks, Mark.
So I'll give an update then in relation to 25-26 across both of the ICS clusters. Really just pulling out the final positions for the financial year and where we're at the moment in terms of external audit, because that's all currently taking place across both the ICBs and all of the acute trusts. So month 12 then, and all the appendices is covered within the report. So what you'll see within the report then is at month 12, the financial positions actually improved across both of the cluster positions. Primarily, it's due to the nationally allocated deficit support that was withheld from some of the other systems that was then released at month 12 and was to effectively flow through to the trust bottom lines and improve their overall financial positions. So what you'll see across the cluster, we had £14.7 million, which when you adjust then for the deficit support, we finished then with a deficit of 7.6 million. So that deficit predominantly sits within Hereford and Worcestershire ICS. So 7.9 million deficit there, which was offset by then a small surplus, 300,000 within Coventry and Warwickshire. The biggest challenge and driver of the non-delivery, predominantly in the Hereford and Worcestershire side, was around efficiency delivery, and it predominantly sat within the Worcestershire acute position. And you'll remember previously at board discussions we've flagged about the financial recovery plan at Worcestershire acute and also the risk associated with that. So I'll come on to that in a minute. So if I just focus then specifically on Herefordshire and Worcestershire, so as I just said, finished with a £7.9 million deficit position. That was before you adjust then for the additional deficit support, which does bring the deficit down to 4.7 million. You'll see then within that 7.9 million that the ICB actually improved its position to a 3 million surplus. Wye Valley Trust was at a £1 million surplus, and the Health and Care Trust was at a break-even position. Worcester Acute then finished with the £12 million deficit. The surplus at the ICB and at Wye Valley were planned. They were all part of how we could support collectively as a system the Worcestershire acute position, which, as we know, was off plan, and we've been flagging that now for a number of months. However, the financial recovery plan that was in place at Worcestershire Acute did not deliver as much as was targeted originally, which left the trust with a higher deficit position than we were originally targeting. That will have some implications, as I flagged previously. Those implications at the moment is that deficit support, probably from Q4, which for Worcestershire Acute was about £11 million, is likely to be recovered within Q2 of 26-27. That will give the trust some revenue and cash flow implications, and we are going to have to work through those and understand what those are, and the trust conversations with NHS England regional team about all of that. The main driver then of the non-delivery at Worcestershire Acute was around efficiency, and the efficiency programme was under-delivered by £15.9 million. So that was the big driver of why the trust was off their financial plan. I think it's fair to say NHS England have been heavily involved in the trust financial position. I think met with the trust now a number of times and requested lots of financial information and assurances, as we're now in 26-27 of where the trust are and the plans for the new financial year. I'll just pick up on capital then within Hereford and Worcestershire. So whilst you'll see the ICS finished with a capital underspend of £2.6 million, we did actually agree with NHS England that the £2.2 million of that would be utilised across Coventry and Warwickshire ICS. So it's not lost to the cluster, but it's just shown as an underspend on the HW side and then picked up within the Coventry and Warwickshire side. I'll just touch on then Coventry and Warwickshire ICS. So you'll see there the position was a £300,000 surplus. When you then adjust for the deficit support, it takes that to an £11.8 million surplus. All of the plans were met within the ICB, the Partnership Trust and UHCW. You'll see within the report then South Warwickshire, whilst delivering a small surplus, was lower than the plan agreed at the start of the year. However, that was offset by a smaller deficit being achieved at George Eliot. This position wasn't unexpected. It had been discussed and agreed for a number of months and discussed with NHS England, so that was in line with that expected position. You'll see there as well within the report, capital across the ICS finished with a small overspend of 600,000. That takes into account the position with Herefordshire and Worcestershire, and again was agreed with NHS England. So that's kind of the 25-26 positions as they finish. That's currently going through audit at the moment. We are now in 26-27. We haven't seen any of the trust financial positions for month one because they all go through now to NHS England. As we've agreed and discussed previously, the big challenge for 26-27 is going to be around efficiency delivery, early identification, early delivery of the plans, and that's something that NHS England will be continually assessing and monitoring for the current financial year. So I'll stop there, Chair, and take any questions on anything related to finance for 25-26 or anything else that anybody wants to pull out of the paper.
Thank you, Mark. Any comments? Stephen?
Yeah, there's a couple of bits, probably just context on the Worcester position, but then there's probably some risks to flag, not just the efficiency, but I think it will be for all providers as well, because one of the bits so I'll flag that first. One of the bits we're nervous of is industrial action and the impact, and it does look likely, I think, where we're at is we are going to, I think it's been described as we're in a long haul now. We are not expecting any resolution to that early, and what we know from the national team is I think it's unlikely that we'll get national monies. So I think whatever it is, so we might end up in a bit of a trade-off again. I don't know, but I think it's worth us really keeping an eye on that one. And the other issue, particularly for providers, that's floating around that we have to kind of quantify is the band 5 to 6 that was trailed by our previous health secretary, and whether that survives, I don't know, but that's another one that sits as a bit of a risk for providers, and we might be in different places with that. But I think, Mark, that's one to watch for both as it goes through. Just in terms of Worcester acute position, we had the recovery plan. We'd always been quite clear it had relatively low amber and really some high risk things that we were trying to get over. The high risk ones tended to be some big financial technical adjustments that people like Mark are far more experienced than I, that didn't quite come through for various reasons, audit and other things at the end of the year. We have done quite a lot of lessons learned, and we are looking at the delivery capacity in the trust. So we are likely to bring somebody in as a kind of, not the old improvement director, but bring somebody in to really just keep us really keen on that and help us. And we've got those live conversations with the ICB and with NHS England. So our last performance review meeting, we went through it in detail, and we've got another deep dive with them in early June. So we're kind of really going through that. Board are really excited on it. So I think we've done a real kind of hard look at ourselves about where exactly did it go wrong, and what do we need to do. Notwithstanding, we've still got a massive efficiency challenge, so we have got to get this right. So I thought it'd be helpful context, and more than happy if other people want to come to us and we can share what lessons are and others, so that we're not closed about that. We're quite open.
Thanks, Stephen. It's good. I mean, lessons always, that's key, isn't it? Is that we understand kind of what we can and need to do differently. And certainly efficiency delivery is going to be a key focus of this year as ever. But also, I think we know we need to transform things, don't we? We can't just sort of, we can't, low level efficiencies, if you like, aren't always going to deliver the financial improvements we need to make. I think I just wanted to certainly bring Mark back in, but I wondered about the deficit support coming out in Q2, I think you said, Mark. That sounds quite... that is presumably returning the deficit support that was provided for Q4. Is that what you're referring to?
Yes, Chair. So the expectation is that the deficit support that was attached to Q4 of 25-26, given the position wasn't delivered at year end, there's a conversation going on at the moment that is going to be withdrawn within Q2, because the deficit support now has already been made for Q1, and in the new financial regime, that deficit support now goes directly to trusts from NHS England.
So that is, I mean, that is significant, isn't it, in terms of what it does around cash flow and challenge for Worcester Acute, I'm assuming, because it will land in Worcester Acute. So I'm just sort of citing that because that just feels like it's quite a big thing for everybody to be thinking about how we respond to that. And I just wanted to check, Mark, as well. I think we've now established that the Welsh income issue has now been resolved, and that's in our plans appropriately going forward, so that's no longer an issue. So it's really the risks will be around efficiency delivery, and it sounds like this quite significant issue around deficit support withdrawal.
So in relation to NHS Wales and the Powys income at Wye Valley, so I wouldn't say it's resolved. I'd say there was an agreement as to how that was accounted for at year end for 25-26 that was discussed and agreed with NHS England. There's an ongoing conversation in relation to 26-27 and what a fair cost of care is for activity that's delivered within Wye Valley Trust with NHS Wales and Welsh commissioners. And NHS England are still actively involved in that. So there's a position agreement gone into the plans for 26-27 that NHS England supported, but we do need still to get a permanent and more financially secure resolution between Wye Valley and Powys.
Okay. Thank you, Mark. I can see Francis wants to come in. Sorry, Francis, felt like I needed to clarify that because that has been an ongoing concern, hasn't it, for all of us, Francis?
It has, and I would love to be able to say it is resolved, but as Mark says, last year we've got an agreed position, so active ongoing discussions with colleagues in particularly Powys Health Board, but also the national teams. So locally, the main focus is on the pathways that we can develop jointly with commissioners and other providers in Powys to do all that we can, particularly around urgent emergency care, to reduce the numbers of people who need to come to the county hospital, and then to make sure we can get them home as soon as possible afterwards. So we're trying to mitigate the impact of the very significant difference in length of stay, particularly for non-elective activity for people who come from the Welsh bit of our catchment area. But yeah, we are still actively working on a permanent resolution, as Mark says, to the cost of care, recognising a different manifesto and legal position sorry, from Welsh Government.
Thanks, Francis. That's really helpful. Stephen?
Yeah, sorry, it was just to build on the Powys issue for Wye Valley. One of the other risks that we need to be keeping a close eye on, and I'm not saying this as any kind of political view, but when we did meet the chief exec and the chair of Powys Health Board, it was the implication there may be from what is quite a significant change in their devolved government, because they've been of one party for such a long time, and there was a not a nervousness, but just a risk of if policy shifted or anything that could change activity flow or might start to influence these negotiations as well. So just one for us to be really sighted on and keep close.
Yeah. Okay, thanks, Stephen. So are there any further comments or questions? No, okay, thank you. So I think, Mark, you just wanted us to note the positions reported, but obviously that it's for all of us subject to audit outcomes for individual organisations, and obviously the position on efficiencies as well, which we've noted in terms of delivery and non-delivery. Mark, anything else to add?
Nothing further from me, Chair, in relation to 25-26.
Okay, thank you very much. Are you happy for us to move on then? Did you want to say anything further on 26-27? Or
there's nothing really to pull out on 26-27 at the moment, Chair. We haven't been required to do a month one position formally. It's just kind of headlines at the moment for NHS England.
Yeah.
And we're still trying to understand how that's going to work in the new kind of reporting regime, because the trust now having to report directly to NHS England and not through ICBs, as was the case in the previous financial year.
Yeah. Okay, thank you, Mark. Well, we note that position, and we'll move on then to last couple of items on our agenda, which are around governance insurance. Hannah, it's over to you for the ICB's risk appetite, corporate objectives and board assurance framework.
Thank you, Chair. So thank you. So yes, so this report sets out the 26-27 framework for board assurance and risk management for the cluster. It does that by suggesting specific risk appetite levels and proposes a set of corporate objectives and priorities, each with their own target assurance level as well. So starting with risk appetite then. So the proposed risk appetite levels and the corresponding statements are set out on page 2 of this report. The position essentially reflects the climate within which we operate, such as the need to reduce running costs and deliver financial savings, but also the level of risks that we are prepared to take in specific areas as a board. So obviously setting our risk appetite clearly is helpful in framing our approach to risk management and establishing what mitigations we might want to put in place and what we're going to prioritise. And going forward, we would also like to explore ways in which we can proactively shape our decision making by utilising risk appetite statements. in terms of corporate objectives then, so this year the two ICBs have agreed to set aligned objectives and priorities, and setting these is of course again fundamental to the operation of the cluster. It provides clarity as to what we should focus on and where we should prioritize our resources, and this is then sort of this is relevant at all levels in terms of board, in terms of directors and all staff, as we use our corporate objectives not just to set our board assurance framework overall, but also to base individual staff's objective on the cluster objectives as well. So the board members have been engaged and fed into the process throughout, and this year our approach has been to structure objectives around the 4 core purposes of the ICBs, with an additional more corporately focused objective as well. So in total there are 19 priorities across 5 objectives, with 7 being given high priority status. So whilst we'll of course endeavour to achieve all 19 priorities and achieve the target assurance levels we've set, a particular attention and resource allocation will be given to those 7 elevated priorities, if you like. David has led this piece of work, and I'm sure might want to add something after me as well. So finally, just briefly onto the board assurance framework itself. So over the next few weeks, we will develop this fully. We've already discussed the need to have really measurable and specific KPIs, and again the NOF will impact on this as well. So for now, what we have done is we have set the initial position in a slightly less scientific way. It's a good assessment of our estimated starting position, if you like, in terms of assurance, and we have also set our target assurance for all those areas. So David, is there anything on corporate objectives you wanted to pick out that I have not mentioned?
Yeah, thanks, Hannah. I would just add that on Monday evening I shared the working paper that we had developed to underpin the corporate objectives, which also included the lead SROs and the kind of the patient impact statements that the board had requested at the board development meeting in April. So hopefully people have had a chance to have a look at that as well. We didn't choose to publish it as part of the overall risk, the overall BAF, but it is there for information if you need it.
Thank you, David. Hannah, was there anything else you wanted to add?
No. Just wanted to say that really I'm looking for an approval of the risk appetite statements, the corporate objectives, and just noting our approach to developing the board assurance framework. Thank you.
Yeah, thank you, Hannah. Obviously, some of these, pretty much all of this has been an ongoing dialogue since about January, I think. So this is really a conclusion of that process. I did want to just personally comment on the people risk appetite, because I feel like it's really important to say it sits a little uncomfortably with me to say that we are prepared to take this level of risk with our people, but the reality, as I think I said in our board development session, is we have had to do that, and that is just, you know, so it's not something we would choose to do under normal circumstances, but we have had to make significant changes and make reductions that we weren't originally intending to do. And therefore, inevitably, there has been a level of risk in those decisions, which doesn't sit comfortably. I think it's important to say it's not a measure of the value we place on the contribution that our people make. We know they make a huge difference, but we've had to make choices around resource reduction, which inevitably have had a knock-on impact on morale and all the other things that we would recognise. So I just think it's important to say that, because it's just reflects the reality of our decision making rather than something we actively would prefer to do. So hence the comment, really. Gail, did you want to come in?
Yeah, it was just a query. Hannah, can you explain how the strategic commissioning toolkit self-assessment that we're going to have, that feels like it's going to be quite a big thing for the future, how does that play into this report, or how would it? What's the relationship between the outcome of that and this?
Yeah, it's a really good question, and Rachel Rachel Dunt might want to come in on that as well. I mean, I think, it's fair to say that we like to have a really clear objectives and border assurance framework set at the start of the year. And of course, we are in a slightly strange year, as in we don't have yet all the information that we need almost to set our priorities and our approach to delivering those priorities. And the strategic commissioning framework clearly will be one of those things we are still waiting on. So I suppose the best answer I can give really at this point is that we will keep this under review. It's a live document, and we will sort of make sure it will be reviewed within that context. And the strategic commissioning committee, I'm sure, will play a key part in that as well. Anything, Rachel, from your point of view on that?
No, I was just going to say the same, Hannah. It's a live document, isn't it? I mean, there might be other things that happen throughout the year which may affect our board assurance and our objectives, and therefore you'd respond accordingly. So I think as and when it comes, Gail, and we've done the assessment, we may want to update in terms of those objectives in the board assurance framework.
That's really helpful. Thank you.
Thank you. It's a really good point, Gail, but I think it's a similar point to the NOF, really. I mean, we're starting the year without exact information on how our success, if you like, is going to be measured through the course of the year. So it's a slightly strange position to be in, but I think just being agile to that and flexible to that is probably the most pragmatic approach we can take. But as Hannah has said, we've always started the year with some semblance of objectives that we want to focus our attention on, but we will need to just keep everything under review as we go, which I think does make sense. Vicky.
I think just to reference really helpful from our last board development discussion, where we thought the alignment with committees would be really helpful. And I think it is very helpful as this sets out, but it shows the triangulation and discussion that we need between all the committees, which I know we've got planned in June, which I think will help to decide how we go from the strategic commissioning committee to looking at the outcomes and that closing that loop through the integrated quality performance and assurance committee. So I think that's going to be really helpful, but just to point out that we are doing some further work on that. As you said, Krishni, it's an iterative process.
Thank you very much, Vicky. So if there's nothing else to comment on, is the board happy to approve the proposed risk appetite levels and the corporate objectives on the basis that we will need to review these as things develop, like the strategic commissioning toolkit, and indeed the oversight framework changes? Everyone happy to support that? Thank you. We then move on to our final report, which is the committee escalation assurance report. Hannah, back to you.
Thank you. So yes, we have, for the past 2 or 3 board meetings, I have given an update on our development of our governance and our committee arrangements. I'm pleased to advise that the high-level committees, the 6 that we have established that report to the board, have now all been set up and have all met at least once. As we've already alluded to in the buff item, so it's a work in progress. There are a lot of conversations about how the committees kind of dock into each other and how they link, and what we can do to make sure we triangulate the information appropriately. We're also getting used to our new role as a strategic commissioner, and that is reflected in how the committees are starting to operate. So that's really just a high-level introduction. Other than that, we have got the summaries and the AAA report for all committees that have met, as well as minutes for information that have been appended to the report. So I don't know if the chairs want to say anything specifically in terms of their own committees, but there's nothing else from me. Thank you.
Thank you, Hannah. Vicky.
I think just to say that this time in preparation for the the highlight report, we've gone into a lot more detail from the first meeting, but mainly because a lot of it is context for the work that we've just been discussing in terms of how we're going to work together. So it's just to explain, we wouldn't normally include as much detail, but it was important for context for this meeting.
Thank you, Vicky. Do any of the other chairs want to come in at all? Don't feel you have to, but equally there is time if people want to comment on anything in the report. Okay, I don't see any hands up. It's there really for board members. It's there for and for members of the public. It's there for transparency about what the committees that are report to the board are discussing. and gaining assurance on. So obviously it's there for noting and for your assurance that the committees are functioning appropriately. So I think we just asked to note that report and receive the assurance around the ongoing establishment of the governance arrangements. So thank you very much, Hannah. That brings us to a slightly earlier close than we were anticipating, only by 10 minutes. The next meeting of the board will be the 15th of July. Before I close this board, there's a couple of things I just want to mention. One is there is a confidential board scheduled, and for members of the Coventry and Warwickshire board, because there's a commercial decision to be made. I think, shall we go to that straight after this, Hannah, because we're running a bit early, but I'm assuming colleagues would want to jump straight on that call who are attending that. So obviously you've been invited to it if you are a member, because it is a formal approval, but it is only for members of Coventry and Warwickshire because it is an approval of a commercial decision. So I will mention that. I would also like to take the opportunity. I think, Paul, it is your last formal public board meeting with us, is it? Or is it not?
It is.
It is. I know. Well, I'm hoping we'll still see you at our development session in June, where we can give you a more informal, say a more informal goodbye. But I did want to take the opportunity to say how much we've enjoyed having you on the board and how much we've appreciated your contribution and your partnership working, and we're going to miss you enormously. So I really just want to say thank you on behalf of the board, and wish you all the best for whatever you're going on to do next.
Okay, thank you, Christine, and thank you, everybody. It's yes, I've enjoyed playing my part, and hopefully for the better. And yeah, look forward to see you all in June and can say farewell then. But thank you.
Pleasure. Paul, is there any official news about what will follow? Is that official now, or
yeah,
not?
So it's out there, and I thought the updates are going to happen. We'll confirm it. So Paul Sator will be joining as the new chief executive. I think his first day is the 26th of June. I leave formally on the 25th. So we're enjoying the opportunity to do some kind of spend more time on transition, get Paul up to speed in terms of kind of challenges and opportunities, and meet some people in advance of that. And no doubt, Christy, with yourself and Simon and other colleagues on the board, there'll be some early opportunities to engage and get to know what's happening across the ICB as we are working. But no, thank you.
Thank you. It's been an absolute pleasure to have you on the board, and we really appreciate all your contribution. Yes, I mean, I've certainly received email communication. I just wasn't sure whether your replacement was an official announcement yet. But
yeah, oh yes, very official.
Great. Well, we look forward to working with Paul. That will be easy to learn his name. But thank you, and look forward to seeing you at the development session. So thank you everybody for contributions today. I'll close the meeting and see colleagues who are jumping onto our other call very shortly, hopefully, and we can make that conclude that meeting as well. So thanks everybody, and have a good day. Bye bye.
Thanks all.